Welcome to nasogastric tube insertion for LPNs. There will be questions to answer throughout this presentation and a couple videos to watch. So what kind of purposes do we have for putting in an NG? Well, if someone is NPO status or insufficient intake for more than 5 days, they may need an NG to help replace some nutrients. Another thing is the decompression of the abdomen for liquids or gases. This is a lot with our bowel obstructions or ileuses. We're going to put an NG down so that we can pull that fluid or the gas out so they don't become too distended. Unable to ingest sufficient nutrients. So again, this is going to be like our little girl that we saw earlier in the video. Where she needed it at night so she could have food intake or calorie intake at night. And then for diagnostic procedures, sometimes people just can't get all that barium down, and they also can't get the go lightly down, so sometimes we have to put in an NG tube so the nurse can assist them in taking that, ingesting that type of treatment. So there are lots of different sizes of NG tubes. We have a 14 to 18 French is your typical adult size, and then your child is going to be a 5 to 10 French. Notice those smaller sizes are going to be smaller because kids are just smaller. We also have different kinds. We have single lumen and double lumen. Single lumen isn't used too much anymore. We more often use the double lumen, which is known as the Salem Sump, is the brand name or the one we usually use. The size used depends on the size of the patient. So obviously smaller kids, smaller tube. And the purpose of the tube. If we are putting a tube down to help someone eat and give them nutrients, it's going to be a smaller tube. If we are putting it down because they're a drug overdose and we need to pull pills out of them, then we're going to use a bigger tube to get those bigger chunks out. So here's an example of a Salem sump. You can see that it has this blue air tube. That's what's going to help us not get the tube stuck to the side of the wall of the stomach. It also has a stopcock so that we can open and close depending on what we need and where we need the medications to go in, or if we're pulling stuff out. The other thing that this has, and you can't see it really well in the picture and we'll look at when we get in lab, is there's little bitty holes all along the sides of the NG, and these holes are what actually allow for the contents to come out. And usually there's a hole right around the tip, and then there's a bunch of holes on the side. So sometimes like one side can get stuck against a stomach wall, but then the other side is not. So assessment of patient, this becomes really important. We want to know their level of consciousness. Are they able to cooperate? Are they able to let us know that we are in the lung, or are they unconscious and they're not going to tell us which way we've gone? Another thing, we want that medical history. One part of the medical history that is incredibly important is any broken nose or surgeries, like nasal surgeries. You don't want to be sticking an NG tube up someone's nose who has had nasal surgeries or a deviated septum or something like that, because you're going to have a hard time and bad things can happen. Another thing, we want to assess for bowel sounds. If none, check with physician on how to proceed. We want to assess for gag reflex. Okay, I have a really sensitive gag reflex, so if you come at me with an NG, I'm already gagging before you even get it down me. So you might want to spray some numbing stuff in my throat prior to doing it. Some people, it's not a big deal and it doesn't bother them. We want to check breathing through each nostril one at a time. If they've got one sinus that's really congested, you don't want to go down that sinus. So just paying attention to the flow of the nasal passageway. And then we want to inspect the narrows, again, for that narrowing or the obstruction. Again, see that deviated septum becomes very, very tricky to try and put an NG down somebody if they've got some sort of structural problems to their nose. And then this will help you decide which nair you will insert into. So there's quite a bit of equipment that you're going to need for putting in an NG. We're going to need the correct size and type of tube for the patient and procedure. And we discussed a few of those things earlier of different things you'll get. We want that cath tip of the 50 to 60 ml syringe, hypoallergenic tape, rubber band and safety pin for attaching the tube to the gown. pH paper, this sometimes you'll see, sometimes you won't. It depends on your facility. Your stethoscope, always a good thing to have when you're a nurse. Glass of water and a straw. Water-soluble lubricant, emesis basins, ice chips and tissues. Gloves, goggles, towels, split tape. Pen light, tongue blade, suction equipment. So if a patient's getting an NG tube put in, you're going to want to make sure that you've explained the procedure to them, because if you come at somebody at their nose with a tube, they're going to want to know what's going on. You can develop a hand signal to stop the procedure if it becomes uncomfortable, but I'm going to tell you now, putting an NG is not comfortable for anyone, so most likely you're going to have someone holding their hands so that they don't just automatically try and grab at it. Explain to the patient that swallowing the water as the tube is being inserted will ease the insertion and will get it more likely in the correct spot. This is just a picture to show you how it goes in and then goes down, and we go into that stomach. If you see like tubes like keel feeds, they'll have white weights on the end of this so that it can float even further down. But typically your NG is going to go in here. You want it to go a little further than this because you're not suctioning much out there. You want it to usually be down in here. So you're going to prepare your environment. You're going to wash your hands, provide privacy, prepare your equipment, raise the bed, and you want it as high as you can get it. Place in high Fowler's position. Place towel over the chest. You're going to put on your gloves, and you're going to measure the tube, nose, ear, and then xiphoid process. And this will give you just kind of a guideline of where you're going to go. So like in this picture, the nose, ear, and then that bottom of the xiphoid process. You're going to mark this distance of the tube with tape. Sometimes you can do it with permanent marker. It's kind of whatever you have that will work. So we're going to lubricate about 4 inches of the tubing. It's going to start in the nose. We're going to give the patient a glass of water and ask them to swallow the tubing as we advance. We're going to ask the patient to tip the head back slightly, gently insert the tube, aim back down toward the ear, and then have the patient flex the head down to the chest as they swallow on some sips of water, and you keep inserting with each swallow that they take. You're going to keep encouraging the patient to swallow sips. If they're NPO, don't worry about it too much because you're just going to suction it all back out, so it's not that big of a deal. Definitely you always use water. You don't want to use soda or anything like that because they can aspirate on a little bit, so you don't want them to get anything but water, as that is the easiest thing for the body to reabsorb. If you get to an area that is meeting resistance or just not quite getting there, just try and twist the tube just slightly, and sometimes that'll just get past like a little bump or something that the tubing might be against. Again, swallowing aids in the tube passing past the oropharynx. So we're gonna, if we have a patient that is in respiratory distress, we're going to immediately withdraw the tube. The last thing you want is a tube down in someone's lung, and believe it or not, it does happen, typically more with patients that are less responsive, so that we get it down into a lung and we can't tell until we do an x-ray or something like that. Typically somebody that has a tube down in their lung, they're going to let you have signs that they are having problems, coughing, turning bluish, or they can just be getting short of breath. Usually there's anxiety and some sort of panic. So you're going to know real quick if you're usually in somebody's lung. Once we get the tube down and the patient's stable and doing okay, we're going to secure the tube to the nose with a torn piece of tape, or they have the NG tube patches depending on your facility. You're going to use a little tape on the tube and then safety pin, either tape or the rubber band to the gown, so it's not tugging and pulling as they get up or they move around. That's the last thing you want, is to have to put it back in just because they accidentally pulled it out. We're going to check placement after the tube is secured. We're going to oscillate for air, so we're going to put it in and we're going to use our stethoscope to listen to the stomach for that air sound. Not a super great way for checking placement, as the lungs are right there as well, so if you put air in, it's going to sound like there's air no matter what. One of the best ways actually is to aspirate for gastric contents, and either using a visual inspection of green gastric contents or using that pH paper. Stomach has a pH of below 4 and the intestines are 6 to 7, so if you know you got too far, if you've got that pH of between 6 and 7. So the final things that you're going to do for a patient with a brand new NG is you're going to prepare them for an x-ray. Most of the time the doctor's going to order an x-ray, a KUB, after we get an NG placed, just so we can see it. We're going to gently wipe the nose with tissue if they have any that lubrication or just drainage from having something shoved up there. We're going to place an adapter, connect to suction, or begin feeding when placement is verified as ordered. We're going to return the bed to a lower position, not all the way down, but definitely we're going to go lower. We're going to make the patient comfortable and put away supplies. We're going to remove gloves, wash our hands, and then just like anything with nursing, we have to chart it. So we want to put date and time and how the patient tolerated the procedure, anything we noticed that was unusual, anything that was difficult, or anything that we suctioned out and right away. So like if you went to hook them up to suction and you noticed chunks of pills, or you noticed coffee ground suction stuff out, those things we'd all want to be documented.
You'll need 14 to 16 French gauge nasogastric tubing, water-soluble lubricant jelly, catheter tip syringe, a suction drainage system, and hypoallergenic tape. Also ready, a glass of water with a drinking straw, and within easy reach of the patient, a towel, tissues, and the emesis basin. Our patient is placed in high Fowler's position with shoulders well elevated. We gauge the length of tube to be inserted by measuring from the tip of the nose to the earlobe to the xiphoid process. Mark the length of tube to be inserted with a bit of tape. We can create a gentle curve in the pliable tubing by winding 4 to 6 inches of tube tightly around the index finger. Then lubricate the end of the tube to be inserted. 3 or 4 inches should do. Have the patient extend his neck back against the pillow and begin the insertion with that slight curve pointing down. Proceed slowly, guiding the tube along the floor of the nasal passage, aiming down toward the ear until you're just past the nasopharynx. At this stage, explain to the patient that he'll have to swallow to help the process along. With the end of the tube now just above the oropharynx, have the patient flex his head forward, take a small sip, and swallow. You'll advance the tube by an inch or two with each swallow. The patient may cough or gag if the tubing has accidentally entered the larynx. You can pause, withdraw slightly, and ease the patient with a sip of water. Be careful, there is a risk of aspiration. Advance to the measured mark and anchor the tube to the cheek while you make sure the tube is properly positioned. Your patient should be able to speak.
Oh, sorry, that's fine, thank you.
You'll attach the distal end of the tube to the syringe. Aspirate gently to obtain gastric contents. You'll observe these are usually cloudy and greenish, but they could also be off-white, tan, bloody, or brown. Once you've verified the tube's placement, secure it with tape to the patient's nose. Clamp the end or connect it to a drainage bag or suction machine and fasten the end to the patient's gown. The head of the bed should stay at an elevation of 30 degrees to prevent reflux and to minimize irritation of the posterior pharynx. The patient should find the discomfort eases in a little while.
Not only is putting an NG in part of nursing responsibility, but maintaining and discontinuing it are all parts of nursing responsibilities. We want, for maintaining, we want to assess frequently. We're going to assess suction. So on this side over here is going to be like your green side, which it would be low. Close to the top is going to be your yellow, which is your higher, and then anything in red, just like anything in red with your car dials, is bad, and that's really high suction. So if you ever have somebody where you're suctioning everything out quickly, you're not going to want to leave them on that because it could do some pretty serious damage to the tissue in the stomach. So maintaining and making sure that no one's played with this or turned the dial to different things so that you come in and when it was supposed to be on low and then all of a sudden we're over here on high, people do mess with things when they shouldn't be. Also making sure that the tube that would be coming out of here is genuinely connected to your patient. We also want to assess what's being suctioned out. Like, is it green? Green is usually good, usually nice stomach contents. Anything that's brown or black is usually not great. Usually means we've got something pretty bad going on. Sometimes you'll get people that have been sucking on popsicles and they'll have just weird colored stuff in there too. So, but that's part of assessing, and we want to make sure that we're assessing how much is coming out, what's coming out, and then the suction that they're on. Site, as far as your site, you want to really look at someone's nose. Between the adhesive and the tube rubbing on it, they could develop a lot of irritation and a lot of sores. So if you notice they're having a lot of sores or starting to break down, we probably need to maintain it and we need to get it documented, and then we probably need to change to the other nair for them, which I'm sure they're going to absolutely love. The other thing that we want to do is pay attention to our patient status. Like, is the NG tube doing what it's meant to do? Are they getting nutrition like they're supposed to be getting from it? Are their lungs filling up with fluid because we have doing some fluid volume overload because we're giving them too much? Or are they getting bloated and distended because it's not suctioning like it should be, and we need to pay attention to that. Discontinuing an NG is pretty easy. You're going to assess the patient and the site, make sure that they're doing okay with it and that the site is not real red and inflamed. We're going to want to verify that order. Make sure that you have an order to DC it, because the worst thing is to get it DC'd and then to have to put it back in because you didn't, the doctor didn't really want it removed. Then you're just going to remove the tape, and then you're going to slowly but steadily remove it. You don't want to like pull fast because the body's not going to like that. You're just going to want to pull slow and steady wins the race. Now, if you meet resistance, you need to stop. I know this sounds funny, but there's no balloon that holds it in like in a Foley catheter. There's nothing that holds it in except for if it was put in during surgery, they might have put sutures in it to hold it in so that the person didn't pull it out. They also may have developed some sort of knot or kink in it, and you do not want to be pulling that through the small areas and small openings if it has turned into a knot. So just stop. So here is an example of a knot that has developed in one. And again, this is why it's really important to ask people what kind of nasal surgeries they've had, or if they've ever broken their nose when they were a kid, or anything like that. This is a true story for us. This was actually a picture taken by a student. We had a patient that we came in, and the staff was going to let us put the NG tube in, but the nurse went ahead and did it prior to us getting there. And she had inserted and it wouldn't go very far, so she pulled it back out, and then she tried to insert again, never pulling it all the way out but just partially out, and by doing that in and out motion she literally got it tied into a knot. Well, guess what? Why was this patient getting an NG tube? Well, because his bowel was distended and he was filling up with gas and starting to have some really big problems. So he really needed that NG tube in. Well, we couldn't get it back out. And they couldn't figure out why they couldn't get it back out, because you should never have an NG tube meet resistance when it's coming out. It should literally just slide out. That's why we always laugh if someone coughs, they could cough out an NG tube. So this patient had to be miserable for a prolonged period because they couldn't get it out, and it was obviously not suctioning with a knot in there. And then he ended up having to go down to interventional radiology, and they had to open his mouth and cut the tube in the back of his throat to pull it apart and pull it out. So this is something we don't see very often, thank goodness, but it can happen. Now, something that's on here that you can kind of see on this tube, you can see this white line that's kind of through here. The reason that white line is there is because that is an opaque line, and that allows us to be able to see it in x-ray. So that's why when they do that KUB x-ray, they can see where that white line is.